Hello and welcome to the nursing process. Today we are going to be looking at the different parts of the nursing process so that you can be successful in figuring this whole thing out. A lot of times when you come from first semester, it just still is very Greek to you. And I'm hoping that when you come into second semester, we can make it clearer and that we can also make it useful, because the nursing process is what it's all about. It's what I use every day when I'm working with my patients. So let's look at it specifically and hopefully answer a lot of your questions. Okay, so the purpose of the this particular audio slideshow is to help you become more and more familiar with the nursing process. It's to help you to be able to do the comprehensive care plan that is required in your clinical rotation with me during this semester. It is also so that you will, and I know Marty uses this term, will have a toolbox when you go into your patient's room that you can utilize to help your patient, and not just vaguely. And that's why we're really going to be working on this specifically, and you'll see me nagging you to do action nursing interventions, ones that really help your patient. One of the things that I want to talk about in relationship to the nursing process is that there's lots of reasons why it's not so easy for most of you to do. First off, you have no foundation based on the nursing process. Some of you may have done the scientific process when you took your science classes, and that is very similar. But the reality is that you haven't been around people watching them doing the nursing process. The nurses on the floor certainly do the nursing process, but it's all in their heads. They're not articulating it to you. And many of the care plans that we're seeing out on the floors nowadays are multidisciplinary, so you don't see it exactly the way we're teaching it, but it is the way that nursing schools are doing it. Maybe by the time you guys are faculty, they won't have the nursing process, but I doubt it. So let me tell you a few things that might help you here. One is that everything else in life that we've had to do, we've had some kind of previous experience. For example, if here I am 15, or I'm not 15 anymore, but if I was 15 and I was going to go and get my driver's license and go and do my driver's training, this would be a new skill for me, but it would be a skill that I have seen for the last 15 years as I sat in the car and watched my parents and other people drive, correct? So I have some familiarity. I know what a stop sign looks like. I know what a green light is. I have some familiarity. I may even think that I know how to do it just because I've watched you so much, but we all know that you have to do it. The problem with nursing process is you haven't seen anyone doing it, and so it is something that you have to learn. I compare it to fog on an island. When you first start in at least this is the way it happened for me. I'm just talking about my personal experience. What happens is that when I first got exposed to the nursing process, I felt like I was completely surrounded by fog, and I didn't know which way to walk. Let's say you're in the middle of an island and you want to walk to the water's edge, but you don't know if you should go to the right or to the left or front or back or what, because the fog is so thick. And you don't know what to do. And so you take a step and it's the wrong one. Or you don't take any steps because you just don't know what to do. The way the nursing process is the more we talk about it, the more we discuss it, the more you use it, it will be like the fog is lifting. And as it lifts, you'll be able to see which direction you need to go. And so it will get better. Okay, but you got to give it time. And the other thing I want to really encourage you is to use as many resources as you can. Ackley is, of course, one of my favorites, but I have recently, in the last year, gotten hooked on Nurse's Pocket Guide. It is Nurse's Pocket Guide by F.A. Davis. I really like it too, but I grab any nursing diagnosis book I can get because sometimes I'll like the EOs in one or the expected outcomes in one book, but I'll like the nursing interventions in another one. So in Ackley, I personally like a lot of Ackley, but I don't like her EOs. So I tend to be looking elsewhere for my EOs. So just remember that. Look in as many places as possible. Okay, so overview. We're going to look at the different components of the nursing process. Being a person that really loves math, I know I'm silly that way, but I really do love math. I kind of look at the nursing process as a mathematical equation. You cannot move from A to B to C in this particular process, and it will not flow if A doesn't go to B and B doesn't go to C. They have to all flow. And if one of them is off, they'll all be off. So when I get to an EO I just can't doesn't seem to be working, sometimes I have to go and look at my nursing diagnosis and see if maybe I picked the wrong one there. So we'll talk about that more as we go along. So in overview, we're going to be looking at the nursing statement. What we use in our program is a 3-part nursing statement, but there's also 2 parts. I'll talk about that. We're going to talk about expected outcomes, nursing interventions, and evaluation. Before we start on those specifics, I'd really like to encourage you to go back and read Section 1 of Ackley. Section 1, it just helped me so much as a faculty member trying to figure out how to teach, how to articulate what the nursing process is. Sometimes it gets into your brain and you can do parts of it, but to teach some people it's hard. But the thing that I like about Section 1, I'm looking through it right now, is that it talks about each section, and it talks about how the nursing diagnosis is, and it talks about what the defining characteristics are, and what the related to is. And so let me talk to you a little bit about that. When you look in Ackley, and if you just go to your Ackley book right now and you just open up your book and you go to a nursing problem, and I'm just going to pick it open right now, and I'm going to go to I opened up to caregiver role strain. Okay, so one of the first things that I see under this section is a definition, and it tells me what that nursing diagnosis means. And what it means is the difficulty in performing family caregiver role. Well, that seems pretty obvious. I picked a pretty clear-cut one. That seems real clear-cut. Okay, so there's the definition. So I go, well, is that true for my patient, or is that true for one of my family members? Yes, it is. Okay, well then now I know I probably have the right nursing diagnosis, but let me look a little farther. And it says defining characteristics. So when I look at the defining characteristics right underneath that, these are what we call the signs and symptoms, the evidence, as evidenced bys, the as manifested bys. They're telling us exactly what I should see in this person for me to know that they are having caregiver role strain. When I look about it, it says here apprehension about caregiver's care. Going on down here, fatigue, GI upset, weight change, anger, difficulty watching, concerns about family members, family conflicts. So I just kind of keep on looking down, and I find the ones that are appropriate for my patient or family member, and I say, yes, I see these things. And these are really, this kind of gives me that as evidenced by that we're going to need in that 3-part nursing statement. Then also the last part is the related to. In the related to, you'll see right underneath that is your etiology. And so this is in nursing language. We are really trying to get away from medical diagnoses, medical jargon in the sense of using it as our primary source. We want to have nursing be its own profession. And when they first started talking to me about this, I went, because I'm just a practical kind of girl, and I just really want to just get it done, get her done. But the reality is that when you look at nursing, we look at everything related to a patient. We don't just look at their medical diagnosis. So for us to look at something like acute cholecystectomy or acute cholecystitis, I'm sorry, is a better way to say it. To look just at that is so limiting because, of course, it'll create a whole bunch of things that we want to look at: pain, infection, all those sorts of things we're going to look at. But we look also at the patient may have hopelessness. They may be having some coping issues. They may be having some financial issues. They may be having some child care issues. We look at all those things as nurses, and that's what makes nursing to me better than being a doctor. And of course, I'm totally prejudiced on this, but that's what I think makes us different, and the nursing process should reflect that. So let's look at first the nursing statement. The nursing statement is made up of 3 parts. So when you go to write your nursing statement, you need to format it in this way. You need to first have the nursing diagnosis, and it needs to be a NANDA approved nursing diagnosis. And the way that you can find those is not that you make them up, but you look in your very last page of your ACLE, and on the hard paper there, you will see a whole list of NANDA approved nursing diagnoses. And each year or two they add more to it, which is lovely because we get new ones that really do help us. Sometimes we've been frustrated that we didn't have something, and then the next year they added it, and we were all very gleeful about that, especially when they came back with the unstable blood glucose. That made me very happy. Risk 4. So you're going to look for the nursing diagnosis. So you're going to look down this list here and find the ones that you can identify for your patient. Then the next thing that you're going to identify is the related to, which is the etiology. So let's say that you have identified one of these, and here we have, I'm going to look down the list here, and I see anxiety. And I'm going to turn to that page, and I am going to go to the page, and I'm going to look at the defining characteristics. Got ahead of myself. Related to. And so it says anxiety. Okay. Change in economic status, environment, health status, interaction patterns, role function, role status, exposure to toxins, familial association, on and on and on. So I look through all these things and I go, well, why is he anxious? Well, I'm looking down as I go down here. I see situational crisis. This is a very common one that we have with our preoperative patients. They are in a situational crisis because of having surgery. And so let's see if there's anything else here that might, nope. I think that's the one that really hits me the most is in relationship to our surgeries. So there's also here threat of death. Some patients do really worry that when they go into surgery they might die, and so that makes them very anxious. So whatever is appropriate, you're going to write that anxiety related to, and anything that's appropriate that you see here under ACLE or you have found to be appropriate that is truly an etiology and not a medical diagnosis can be written down there. Now you'll find in the very, very front of ACLE there is a section that you guys all like to use an awfully lot. It's kind of darkened. It's got darkened edges on the pages. And this is a section. It's right after section 1. It's section 2. Surprising. Section 2 that you'll see a list of medical diagnoses and then nursing diagnoses underneath it with related tos. As long as you get it from that section, I'm okay with that. You'll also find some in different resources. Then the last part of this 3-part nursing diagnosis is as evidenced by, and this is going to be your signs and symptoms. So what did you see in your patient that made you think they were anxious? List all of them. And if you're having a little bit of trouble of figuring that out, remember, ACLE also has a whole list here of defining characteristics, which I just cross out that word defining characteristics and put signs and symptoms or as evidenced by. And I look down here and I see what of these things did I see that Ackley's pointing out? Well, the patient was apprehensive, yes. The patient had insomnia, yes. So I would write these all down. The patient had facial tension, yes. I would write that one down. So all of these would be written down that were appropriate. Sometimes also in this section, I'll also put any kind of lab work that might be an indication of the problem. Certainly, when we think about excess fluid volume, if you've got a patient with kidney failure, you'd want to write down those labs that are abnormal. So, 3 parts. The nursing diagnosis, related to, which is the etiology, as manifested by, which is your signs and symptoms. So now let's look at some examples here so that you can go ahead and see what's right and what's wrong here. And hopefully by working through each one of them, it will become clear to you. So we're just going to identify the 2-part. We're going to leave out the as manifested by, and we're just going to look at the nursing diagnosis and related to. So let's look at the very first one here, abdominal hysterectomy related to ovarian mass. So now, is abdominal hysterectomy a nursing diagnosis? If you're not sure, go and look in the very back and you'll see that it is not. Abdominal hysterectomy is a procedure or a medical diagnosis. And so this is definitely not a NANDA-approved nursing diagnosis. Related to ovarian mass, this again would not be what we would call a typical etiology that we would use. And in fact, there's no point in looking any farther at this particular nursing statement because we know it's wrong from the very beginning. So let's move on to the next one. Acute pain related to abdominal hysterectomy. Okay, well, acute pain. Is that one of our nursing diagnoses in the back? Yes, it is. It's one that we use a lot, especially in peri-op. Related to abdominal hysterectomy. Now, is that an etiology? No, that's a procedure or a medical diagnosis, and so this would not be a correct nursing statement. Let's look at the third one. Altered comfort related to actual tissue damage. Well, this looks pretty good. Let's look at this. Altered comfort. Is that one of our problems? So I'm looking in the back, and I'm looking under here, and I'm looking under comfort, and as I look down under comfort, I see impaired comfort, and I see readiness for enhanced comfort, but I don't see altered comfort. So that's just a little bit of a glitch there, but it is not an approved nursing diagnosis. So that should not be used. Now, as for related to actual tissue damage, that could be actually a possible etiology. So we're so close here on this one, but no, what's the word? Oh, well, it's not right. So let's move on to the next one. Now, tissue integrity impaired related to mechanical factors. Now, a lot of you will write it impaired tissue integrity, and that's probably the way I would write it, but that's just not the way they always write it in the NANDAs. So I tried to be very legalistic here. But I'm fine with impaired tissue integrity. Let's go and see if that's in the back. And I'm looking under tissue integrity, and yes, there it is, impaired tissue integrity. And then I'm going to go back and I'm going to look at this particular one and see if I can, if related to is correct. Now, it looks correct as far as if I'm saying related to mechanical factors. Well, certainly my tissue could get impaired because of mechanical factors, shearing and things like that. So that sounds totally plausible to me, and I can double check it if I'm not real sure, and especially when I'm a new student working, I do need to kind of verify things. So I'm looking here under impaired tissue integrity under related to, and as I look through, I see altered circulation, and here coming down mechanical factors such as pressure, shearing, and friction. So definitely that would be one that would be true. So there we go. That is the correct one. And I hope that all of you were able to see clearly why one was better than another. Now, let's go ahead and identify the as manifested by or as evidenced by. You'll see, depending on the school that you go to, will depend on whether they say AEB or AMB. You'll hear me going back and forth because I've been at different schools and said it different ways, and so it just depends on what I get started on that day. But as evidenced by is the signs and symptoms that we see in our patient. When we do our assessment, we're going to see these abnormal signs and symptoms that are going to clearly tell us of a potential problem. Also, when we look in the chart, we'll see things that will tell us that perhaps this patient is having problems in this area. Another thing that we can do is we can see this also under the heading of defining characteristics in Ackley. So let's look at each one of these and see what you think. Inspiratory and expiratory wheezes bilaterally. Now, is that a sign and symptom? Yes, it is. So I would expect this to be under your as evidenced by if we are talking about probably something to do with breathing or gas exchange. Impaired tissue integrity. Is that a sign and symptom? No, not really. What it is a NANDA. It's an impaired tissue integrity, but certainly that could be a problem, but you need to be more definitive, such as you would say abrasion on the right ankle, or mucous membranes that are bloody and painful. You would describe what you saw. BUN of 50. Yes, I would expect this be one of my signs and symptoms that I might see illustrating that problem. Whatever that problem. The problem in this case would I'd be looking at fluid excess. Assessed bowel sounds Q4 hours. Well, we haven't gone over nursing interventions, but that is what that is. That is not a sign and symptom. That is something that you are going to do to try and remedy a problem for your patients. So when we look at these four, inspiratory and expiratory wheezes bilaterally and a BUN of 50 are certainly the ones that I would identify as evidenced by. Now, let's talk also about risk for nursing diagnoses. What we've been talking about up to this point has been actual nursing diagnoses, actual nursing problems. So, for example, if I have a bed sore, I have impaired skin integrity or impaired tissue integrity. If I have diarrhea, that is an actual problem. But a lot of the things that we deal with, especially in peri-op, is some risk for or potential problems. We have the potential when our patient goes into surgery that they will not breathe as fully as they need to. And so we will write up a risk for gas exchange, impaired gas exchange, or a risk for ineffective airway clearance. So these are ones that we're going to look at. So what is the difference when you're writing this up versus an actual problem? Well, first off, there's only two parts in a potential problem or a risk for a problem. Those parts are going to be a nursing diagnosis. So you will have the risk for aspiration as one that I like to talk about specifically. Risk for aspiration, and then you're going to talk about what the risk factors are. So if you take your Ackley, let's go ahead and look under aspiration. And I do expect that you should just really use this book a lot to get it, your ability stronger on it. Okay, so we look at risk for aspiration. And when I look at this one here, the definition is at risk for entry of gastrointestinal secretions, oropharyngeal secretions, solids, or fluids into the tracheobronchial passages. Well, definitely my patient has a risk for that. And so especially one that I have, let's say that has a tube feeding. So I would say risk for aspiration, and then I would put, you put a colon after that, And then you say risk factors and you list the risk factors. So looking under here, here are the risk factors for this patient. And so if I have a patient that has decreased gastrointestinal motility, I would list that. If they had a depressed cough, I would list that. If they had a depressed gag reflex, that. So many times when I'm looking at this, I'll have a patient that I'll say depressed gag reflex, I'll say gastrointestinal tube, I'll say impaired swallowing, I'll say, I'm looking down there, reduced level of consciousness. So I would list everything that would be appropriate to my patient. And so risk for aspiration is a good one to look at, but there's a lot of other ones that we can do risk for, and you need to list what are the risk factors that you think are going to make, that could make this move from a potential problem to an actual problem. Okay, let's talk about similar nursing diagnosis, because this is going to come up, and we get this a lot when we talk about it in clinical and post-conference where we do our interactive nursing care plans. But there's a couple of ones that are very similar, and so you really have to read them and see, do they fit your patient? Let's look at the first one, impaired skin integrity and impaired tissue integrity. They're both very similar, and many times you can use them interchangeably. But what is the difference? So let's look at first skin integrity and see what it says. I'm looking at skin integrity, and let's see. It says altered epidermis and or dermis. So definitely there's some kind of, and it says here, defining characteristics, destruction of the skin layers, destruction of the skin surface. Okay, and then when I look down here, I look back here at impaired tissue integrity. It says damage to mucous membranes, corneal, integumentary, or subcutaneous tissue. So this is a much more broader definition, isn't it? It includes so many other things besides just the skin. So this one is really useful if you're looking at mucous membrane issues and other issues, but typically skin is the appropriate one for most of our patients that we see in the hospital. Impaired gas exchange, ineffective breathing patterns, and ineffective airway clearance are also ones that get mixed up. So let's look at them. When we look at gas exchange and we look at the definition of that, it says an excess or deficit in oxygenation and or carbon dioxide elimination at the alveolar capillary membrane. So what we're basically looking at here is that gas exchange in the lungs is not happening. So what will we see? We're going to see here, we're going to see some abnormal breathing. We're going to see some confusion. We're going to see some labs that are going to be off, and we're going to see some tachycardia, and you'll see all the listing here of different signs and symptoms under defining characteristics. So why would I pick that one, or would I pick ineffective breathing? So I'm moving that, and I'm moving a little faster because I have these marked. But when I look at this here, under ineffective breathing pattern, it says inspiration or expiration that does not provide adequate ventilation. Oh, that's very different than gas exchange, isn't it? So you can have an adequate breathing but still not have good gas exchange. But then you can also have good gas exchange but not be breathing good enough. So the signs and symptoms here are we get an alteration in the depth of breathing, altered chest excursion, let's see, inspiratory pressure. Now they're talking a lot about vital capacity and things like that. But when I look at this some using the accessory muscles to breathe, looking a lot like a COPD, but so does the gas exchange, because at the alveolar level, a COPD certainly has compromises. So let's look at another one here that also can be one that tortures you guys and me, is ineffective airway clearance, inability to clear secretions or obstruction from the respiratory tract to maintain a clear airway. And so then we're going to look at these signs and symptoms: absent cough, rales, changes in respiratory rate, difficulty vocalizing, diminished breath sounds, excessive sputum. And so here I am trying to decide which one would be most appropriate. And so many times what I'll have to look at is I have to look at those signs and symptoms. I have to look at what is the underneath, what is the etiology of why my patient is having problems in this, and what is my focus of my interventions. Do I want to help them to be able to have a better gas exchange? So do I want to help them with their oxygen and CO2, or do I want to help them with their ability to breathe, or do I want to help keep their airway clear? So these are the things that I have to ask when I look at these, because they can easily go from one to the other. And then lastly, activity intolerance and fatigue is one that I see students go back and forth between. The one thing that you have to remember about activity intolerance is with activity intolerance, they must have some sign and symptom that shows that they are not tolerating the activity. And that just, it really shouldn't be just an expression of fatigue. It should be some kind of vital sign change. Okay, so let's move on to some more stuff. Now let's look at expected outcome. In expected outcome, so you figured out your nursing diagnosis and your three-part. Now we're going to figure out what should be our goal. Now remember, there's lots of words that are used with expected outcome. Most people say like short-term or long-term goal. Some people call it nursing outcomes. We've been pretty much calling it expected outcomes here at MiraCosta EOs. But the bottom line is that you want to pick a goal for your patient, an outcome for your patient that is something they want and you want, okay? And sometimes it's more they want or it's more you want. But we do have to figure out something that will really meet this patient's needs. So there's certain parts to this. There's 4 parts. It always starts with patient will. It must be measurable. It must have a time frame, and it must be realistic. So when I say the patient will, and one of the easiest ones to really talk about is, let's say we have acute pain related to mechanical factors, and as manifested by grimacing and facial grimacing and an expression of 9 out of 10 pain level. So patient will what? What does your patient really want? Your patient wants the pain to be gone. So you have to figure out what is realistic and what is can be done within a certain time frame. So let's say that I say I would like my patient to have a pain level of 3 out of 10 by the end of my shift. Now then I have to think to myself, is that realistic? And if I think it is, then write it down. So sometimes we're wrong. And sometimes at the end of the day, when we go to evaluate, we're going to say, well, I made it too short of a time frame, or, I was being way too optimistic. 3 was just not possible on the first day post-op. 5 was more realistic. And so that's okay. Just because you haven't met your outcome, as long as you're modifying based on what you learned, that's what the whole nursing process is about. One of the things that I do want to encourage you is to be realistic. It's so easy to go into Ackley or into any of our books and say, oh, okay, I have a patient that's immobile and they have a mobility issue, and so I see one of the EOs here. Ackley's written is the patient will walk to the end of the hallway, and I think, wow, that's a good one. It's clear, it's measurable. Okay, by time frame, well, okay, my patient's really ill, so maybe if I put it out a couple of months, they could do it. And then you have to say to yourself, is it realistic? And a great example I had was a student that said, my patient will walk to the end of the nursing station by, and put it 2 months out. But the problem was the patient was a quadriplegic, and there was no way that they could walk. But that was a real glaring one. But many times you guys come up with stuff like this, because you see what Ackley writes, and then but you're not thinking about if it's going to work for your patient. And the other thing that you have to also think about when you're writing about measurable is you have to think that another nurse has to be able to measure this. And it's so common for us to want to say increase appetite or increase weight, but what does increase mean? To one nurse, it might mean that they increase their weight by 2 pounds in 1 week. Another nurse, it might mean that they gained 1 pound, or anything. Let's say another example would be eating. Well, one nurse might say increasing your appetite might be they ate 50% of their tray. Another nurse might think it should be 100%. So we can't be that vague. We must make it so that any nurse could walk in and measure the outcome exactly the same way as we would. And remember, I know that when you're doing your care plans, you don't really, you're always making them just for yourself, but most care plans in hospitals, all health care plans in hospitals are being used by all the nurses every day. So even though we don't see them being used as actively as we would like, that is the purpose of care plans. And even though perhaps we don't see it as active as we would like, still in our minds we are running our nursing process all the time. And then remember that after you've done your expected outcome, it does have to relate to your nursing diagnosis. So you can't change problems. Like you can't have acute pain and then say patient will walk down to the end of the hallway, because that's a mobility EO. Okay, so you got to think, if you're more focused on them ambulating, well then your problem really should be a mobility issue. Otherwise, the goal should clearly reflect something to do with acute pain. Okay, so let's identify an expected outcome. Let's get some choices here. First one is patient will be mobile. Well, it does fulfill the first criteria that the patient will, but is it measurable? And does it have a time frame? No and no. And is it realistic? Well, we don't know because we don't know this patient. That's the problem about doing things on PowerPoint. But okay, so we definitely agree that one is not one. So let's go to the next one. Patient will ambulate to the nursing station by the end of second post-op day. And so let's say it starts with patient will. It is clear they're ambulating to the nursing station. That's very clear, and there is a time frame. We don't know if this is realistic. We don't know what the nursing diagnosis is, but we're gonna assume that it is correct and that it is appropriate. I can't write everything down here for you guys, but this would be definitely appropriate for a mobility nursing diagnosis. And then let's look at the next one. Patient will increase his nutritional intake by day 2. Well, patient will is true. Increase, we talked about that. Increase is not a good word. Sometimes it's so hard to find another word to use there, but that one doesn't work. Too difficult, too vague. And by day 2. Yes, in this case, day 2, I prefer when you make up your comprehensive care plans for me that you would say a date there by, December 22nd, But since I'm trying to make this PowerPoint for any semester, I'm trying to keep it a little bit more without dates, but I would prefer dates when you do your comprehensive care plan. I hope I didn't mess that one up. I said that so many different ways. Anyways, let's move on to the next one, which is patient will turn frequently from side to side. Well, we started it off right. Patient will turn frequently. Well, what does frequently mean? For you that might mean every hour. For someone else it might be 15 minutes. I one time had a patient, I said to him, I really want you to do your incentive spirometer about 3, 4, 5 times an hour. Every time you see a commercial, this is when commercials weren't as often, or now what I say to them, whenever you see a nurse walk by, to do your incentive spirometer. And so he said great, and he did all the stuff. And the next day I came in, and he was just exhausted. And I said, what's going on? And he said, I was up all night doing that incentive spirometer. And I said, oh, no, you're not supposed to be doing it. You need to get your sleep. This is only while you're awake. So it's amazing how people can misinterpret what you say and what you mean, and you think it's clear, but it's not. And this is true here of your EOs as well. So what could be frequent to one person would be another definition to someone else. So looking at what one is the correct one, we agree that number 2 is the correct one. Okay, so now let's look at nursing interventions. That's the next part of our nursing process. And nursing interventions always start with the verb. You always should assess your patient first. I always put that as my number one nursing intervention. Assess such and such, such and such, such and such, such and such. I usually lump them all together. Put all my assessing all in one intervention. Because I do have to do all of that assessment. I have to have a baseline on how this patient is doing for me to be able to know how to care for this patient. But the reality is that assessing is a very passive nursing intervention, and it's, to me, this is totally my opinion. I feel that a patient needs to have action assessments, things that you can do to really make a change. It's great that I assess what your pain level is. It's great that I assess your verbal and nonverbal reactions to pain. But the reality is that unless you get rid of my pain, you really haven't helped me. So assessing is vital for us to make the right decisions, but please focus in on action NIs for me. I really want to see what you're going to do to help this patient to get rid of whatever that problem is. And this has to relate to the EO. So whatever your EO is, if let's say your EO is to get your patient to walk down the hallway, then all the interventions need to be interventions that will help your patient be able to, at some point, walk to the end of the nursing station. So let's identify a nursing intervention. Prevent infection. Well, prevent's a pretty vague verb. Infection is a pretty vague thing. I mean, we want you to prevent infection, but you need to be more specific. Apply Neosporin ointment to reddened area on right heel, Q shift. Love it. It's got a verb. It tells me exactly what to do and how often. And of course, this would be something that would be appropriate for some kind of a skin integrity issue that we're trying to resolve. Here's another one. Patient will increase his weight by 2 pounds at the end of 7 days. Well, this doesn't start with a verb. It looks a lot like an EO. In fact, I would say it is an EO because it is patient will and it's defined and it's got a time frame. So this is definitely not an NI but an EO. And then the last one here is assess bowel sounds Q4 hours. And so it starts with the verb and it's something that you need to do for your patient and it's assessment. It's one of my more passive ones, but it's definitely one that we do need to do. So looking at this one, we have 2 that are correct as far as nursing interventions, and that would be number 2 and number 4. At the very end of all this, we do evaluation. Now, many times we don't do evaluation because we're writing our care plans after we take care of the patient. That is not preferable. We really should write our care plans before we take care of our patients. But the problem is that there's so much work to be done before clinical preparing that adding the care plan just got to be too much, and so that's why we put it to later. It used to be we did ask our students to do their preclinical search work with the patho and labs and meds, and we had them do a care plan. But we found that was, well, you already know how difficult it is to get all the paperwork done that you do, much less adding the care plan. But if you were taking care of this patient in the traditional way that you should, you would be evaluating whether you accomplished the EO. So at the end of the day, let's say that you had a goal that your patient's pain would be a 3. And so you say to yourself, did I meet or not meet this goal. And so I would define it as met or unmet is the way that you write it. And so is my patient now at a 3? If he is, you say met. If he isn't, you say unmet. But if it is unmet, you need to clearly say why. In fact, I kind of like when you say why with the met as well. You can just say met and pain, patient's pain 2 out of 10, or unmet, patient's pain level 5. But then I want to know, why didn't it get met? Was there the NIs that I put in place, were they not appropriate to help, or was it not realistic, or do I need to wait more time? And many times what it is, it's unmet and we need more time, or we thought that we could do something and it didn't turn out we could, or whatever. So this is where you have to explain, and then you have to decide whether you need to revise your NIs. And if you're and sometimes you have to, but most of the time it's a thing that we just need to wait on. So let's identify the correct evaluation. Met, well, that's good. I'd be okay with that one. Unmet, I wouldn't be okay with that one because I need to know what is going on if it's unmet. And then here, unmet, patient MPO and unable to take diet as planned. So we could say we wanted them to consume 50% of their diet for lunch. That might be our goal, or for during our shift. And then the patient ends up being made MPO, and now that goal doesn't work at all. And that does happen. So in this particular case, the correct answer is number 3. So in summary, follow the guidelines that I have put down here. That will help you to simplify it, to make it a little less chaotic. Follow the rules, how to phrase each of the phrases, what the rules are, as far as patient will, measurable, time frame, etc. Read ACLE, especially Section 1, really important, and read the individual nursing diagnoses so that you can really know that you have the right one. Use other resources such as Nurse's Pocket Guide. Especially Nurse's Pocket Guide has a lot of good nursing interventions that are more acute care, whereas ACLE is a little more community health-based. And then, of course, you just have to practice, practice, practice. This is not something that you learn overnight. I hope that I lifted some of the fog on this particular issue for you. I'm hoping that it was a really good turn on the fan and really blew a lot of that fog away, so that it will help you to make this a little easier. And I do look forward to seeing you guys and working with you each week on care plans, and hopefully taking away some of the mystery that has to go with this and make it a little more concrete for you, so that you use this all the time in your practice, whether you have to write a care plan or not. So good luck to you, and I'll see you soon. Thank you. Bye.